Just happy to join you back here today and talk about the causation analysis. And for the sake of just the flow of the presentation, I would like to introduce Dr. Hankey and do his introduction, but I will be doing the first two slides and the very last two slides of the presentation of this. So I want to thank Dr. Hankey for joining us. He's just been a great advocate, great advisor, medical advisor with IMO. Many of you may know him already. He is graduated from North Texas with his degrees, and then Texas College of Osteopathic Medicine with a doctorate in general medicine. He completed orthopedic residency at Northeast Community Hospital. Hankey is board eligible in orthopedic and served as on the medical advisory committee of U.S. Congressman Joe Barton. Dr. Hankey is private practice as a Texas orthopedic consultant where he specializes in arthroscopy of the shoulder and knee, as well as treating general orthopedic injuries, which he handles quite a few of our cases, so feel free to chime in and ask questions as well. He has practiced orthopedics in the Dallas-Fort Worth area since 1987. He's no stranger to workers' comp in the world of managing injuries, and we're just very, very blessed to have him part of our team within our network environment. So from the scope of causation, why did we select this particular topic? Well, primarily because it is a topic that seems to be questioned a lot. Based on who the party is, what can you give me in causation? So we're going to talk about this, but before we do, we want to talk about the legal standard for causation, the definition of that extent of injury, causality in workers' comp, understanding the reason why it's important to address causality, and then how the IMO team fits in with all of this. And so along those lines, it's important that we understand why we have to ensure that the carrier is liable, and then there must be a policy in place of insurance, workers' comp, in place covering employees of the employer. The injured worker must prove he was an employee, because that's always questioned out there is, did this happen at work? Was he an employee of the employer like he said he was when he walks through the door? And ensuring that the date of the work incident and that he reported it within 30 days to his employer. The work incident must be shown to have been a substantial factor, very critical in bringing about the injury, without which incident the injury or diagnosis would not have occurred. And there is a case here cited that the standard did apply to the initial injury as well as to the extent of injury disputes to validate that. A dispute over the entire claim must be filed within 60 days of the date of the insurance carrier, which gets notice of the claimed injury. The 60-day time limit does not apply to the extent of injury. Now, this came specifically from Janie Stone, our attorney, who indicated to ensure that we document and say this to you, that generally except for injuries within the scope of a layperson's knowledge, such as a broken bone, after a fall, the expert medical evidence is required to establish this. As they do court-specific case, the opinion must be the standard of reasonable and medical probability. Dr. Hankey's going to talk about that from a medical perspective, that probability being so critical. There was a case, the Sorn versus Lawton in 2009 in the Supreme Court case that held up that the carrier has 45 days from the date it receives the medical bill for treatment to an extended injury by which it must file a dispute. And so many times we do hear from providers, why is it taking so long? And do I treat and may not get paid for? How does that work? Well, in the network environment, the network is obligated to pay for the first $7,000 of treatment because, again, the law took into that account. We did not want to treat someone and them not get paid or get the services that they needed. Until the time that the compensability date time is validated as compensable, then that $7,000 is no longer. So if it's $4,000, it stops there because the PLN or something has been documented. As a rule of thumb, the carrier can still dispute the extent, but that is kind of the rule in terms of the time frame. The AMA guides, which we use for the disease and evaluation of injury causation, is the second edition. and it provides guidance to the doctors. And in fact, I know Dr. Jones, who's here with the Care Now HCA, also teaches causation. Many of the providers out there who do that understand that, but it is critical that we come to the circle to understand how it's documented and in what capacity. So, Dr. Hankey, please join me up here if you would, and we'll get started with the causation.
Because I wear multiple hats, I have bias like everybody has. So first thing I need to tell you is what my biases are. First, I'm an orthopedic surgeon. I look at it from the point of view of an orthopedic surgeon. First line, orthopedic injury treatment, but not first line patient care treatment. Not always, but most of the time I'm getting it from somebody else. But there's somebody in front of me between me and the patient. And that's important to know because we can take all this data of causation and compensability, we can take it one of two ways. We can take it prospectively or retrospectively. Well, when the adjusters and the people, the carrier sees this stuff and analyzes it and tries to make sense out of it, they're usually looking at it retrospectively. When we, especially the ER doc, who oftentimes sees the patient first, or when the first line primary care docs do it, any of the OCMED clinics, this is where you can prospectively take this data, the information that you need to take. And prospectively taking data with all of this in mind, with these tools in mind that we're going to talk to you about, that will give us so much more information about and predictability for causation and compensability than trying to do it retrospectively. So quality of records is absolutely crucial from the moment the patient gets hurt. It is my unfortunate privilege sometimes to look at this from getting it as an orthopedic surgeon or getting it reviewing charts and papers, that half of the records are ineligible, and you can't read them. They're written as scribbles. That's of no value at all to us. It has to be legible. And so I don't care whether it's coming from the ER doc who's in a big hurry, or the primary guy, or the PA, or whoever it's coming from. It's got to be legible. And you need to be thinking about these things when you're asking the patients questions and when you're dealing with the patients, even if it's at the adjuster level, when the adjuster's doing a telephonic conversation with the patient. You need to be very specific on all these items so that you can rule in or rule out the things, and you can get good prospective data, because that's what will hold up in court. That's what the judge and the attorneys and the reviewing doctors and DDs and everybody else are going to be asking for, is prospectively taking data instead of just looking back and saying, okay, let's see if we can find something that tells us that this is actually compensable. So prospective gathering data is crucial. Definition of injury. It's damage or harm to physical structure. It's real straightforward. It can be disease, it can be trauma-induced. It has to be measurable and it has to be quantitatable. Patient coming into your office and giving you only "I have pain" is not something that's going to hold up to muster. It's not going to prove causation. It has to be quantitatable. It's not a feeling, it's not an opinion. And it can't be unmeasurable. Extent of injury. It's further harm caused by medical care, compensable injury, or part of the compensable injury. Anything that worsens the condition that we're paying for as far as care on the original compensable injury. If a doctor does surgery on one of our patients and he causes a complication, that's still included in the compensable injury. Any medication that we give him, any complications from the medicine that we give him, is still included in the compensable injury. So, yes?
What about, so we just had one today. What about someone that has a back injury and is at home and their leg gives way and they fall on their hip and they come to the doctor and say, my hip hurts because my leg went out because of my back injury?
We'll talk a little bit further about the bane that we have, our sack of rocks to carry. There's no easy answer to that. If the weakness of his leg, which was caused by his original injury, he's got loss of reflex, loss of quad strength, and that causes him to fall down, that's ours. That's ours. And I've seen lots of decision and orders that come from the state that indicate that. So it has to be relatively clear-cut, and it has to be, for most people, plain sense kind of stuff. If the patient was out playing racquetball and fell down, not so much. But if the patient's just walking around the house, or if he's back at work doing light duty, and his leg gives out on him, and it was witnessed that it was a give out leg, and it was the proper leg, okay, yeah, then that will be considered compensable, absolutely. If he's getting nonsteroidal anti-inflammatory medication, and he's been having it for 6 months because of this problem, and he gets an ulcer, that's our ulcer. Okay, if he gets erosive hemorrhagic stool, that's our problem. We've got to deal with it. If we give a patient medicine and it causes a complication, the state says that's ours. That's the way the system is. You have a traumatic limb injury, an amputation, crush or rapid, and you get a bad anemia. That anemia is our anemia. That blood loss was due to his injury. So even though it's not directly related, it's indirectly related, it's still, you can prove direct causation. The question you ask is, without the original offending problem, would this have occurred? And then the key is, in all reasonable medical probability. Ketzen's already used that term. You need to use that term over and over. You need to burn it into your mind. In all reasonable medical probability, because when you go to DNO, decision and order by the state, and DDs and people who review these things, they're all looking for the same prove-up, and that is in all reasonable medical probability. What does that mean? Greater than 51% or more. Not preponderance of the evidence necessarily. Not in all. I don't know what the lawyer term is for the criminal cases. But all you need is 51%.
Beyond a reasonable doubt.
Beyond a reasonable doubt. We don't have to do beyond a reasonable doubt. All we need to do is in all reasonable medical probability. And that's a subjective thing. There are two terms that we're going to throw around here, aggravation and exacerbation. Aggravation of a pre-existing condition is included in the compensable injury. Okay? And that is a big problem. It's an enhancement, acceleration, or worsening of the original condition, and it's typically a permanent change. That's the key, permanent change. Now, you have a mild bulging disc. It's documented and it's pre-existing, for instance, or it may be the compensable injury. And you fall down off of your fork loader, and you have excruciating shooting leg pain, and you go back and you see a big disc. Even though there was some pre-existing disc there, it's still compensable.
Now, is that considered a new injury, a new claim?
No.
It's under the original?
It's exacerbation of the pre-existing condition. Yep. If there's a claim already.
Right.
Okay. Now, if there is no claim, and all they have is an old problem, may or may not have been related to work injury, then that's a new injury. Okay. But if you have an ongoing claim, then that's part of the same claim. Patient has mild chondromalacia at the patella brought up on MRI scan. And he slips off of the last step of his truck and comes down and lands right on his knee on that metal step on the big 18-wheelers, and he feels this big crunch. And now the MRI scan says he's got a 1 by 1 centimeter loose body that came off the patella. That's aggravation of the original condition, and that's, even though he had chondromalacia, can't deny that claim. Because that's a definite, plausible, in all reasonable medical probability, that was caused by this event. The event caused the outcome, caused the medical state that the patient's in at that time. Exacerbation, basically temporary worsening. The law, I think, says if you have a pre-existing non-treated medical problem and it's aggravated or exacerbated, it's still considered compensable. But I think in terms of exacerbation, there's a lot of wiggle room in here. And exacerbation means you're a diabetic and you have surgery and you take some medicine and you have an anesthesia and it increases your stresses and your blood sugar goes up for a while. That's a temporary exacerbation. We don't buy your diabetes. Okay? Although that did temporarily increase it, that's a pre-existing medical problem that that patient had all the time, and we didn't permanently change his diabetes. If he has surgery and we give him medication for that and has liver failure because of the toxicity of the medication, that's a new problem, that's a big problem, that's our problem. That kind of falls back to aggravation. Not even aggravation. That's a complication of the original injury, which is ours. Pre-existing medical problems. They're the bane of the workman's comp doctrine. They're a large source of problems for us, for the patients, for the insurance companies. The best way to deal with pre-existing medical problems is to document, and then document, and then document. Okay? Prospectively documenting. And one of the things that we'll talk about a little bit later too, but I want to hit it again here early, is that if you don't ask the questions, you won't know the answers. If you don't ask them in their history, first line docs, PAs, and also the adjusters doing their interviews, if you don't ask questions, you won't know that this guy was a hardcore pre-existing brittle diabetic. Okay? You won't know that he had other medical problems. You won't know that the person who's telling you they got bad carpal tunnel has had thyroid disease and diabetes mellitus for the last 15 years, and they got a bad thyroid. So you have to ask the questions so that you'll know the pre-existing things. And just because because they're pre-existing doesn't necessarily mean they're covered. The key again is that the condition would not exist had the person not had this injury. Key on pre-existing. The old example that I gave you a while ago. A patient can have some mild DJD in the knee joint, okay, and you fall down and bust it up real bad. An easily recognizable traumatic injury that a layman can understand. Okay, you tripped and fell on a concrete floor and you felt this pop. That is compensable. There's causation there. But if you've got a patient that's got grade 4 end-stage DJD throughout their entire knee and they fall down, now they say we need you to put in a total knee force. No. That's a contusion, and it's not compensable. There should be no causation there because prior to the injury, the patient already had a worn-out knee joint. That can be documented. And oftentimes if you do the right studies, and again, it's gathering data, okay? It's gathering data. If you do the right studies, you can prove up the fact that this patient's problem was there in the past. You go dig into his history. Oh yeah, he's had 3 arthroscopies in the last 15 years. They're going to volunteer that sometimes because they're looking for a new total knee. So you dig hard. The docs dig hard. You listen to your physical therapist because sometimes the patient will wag their mouth to the physical therapist and tell them all kinds of good stuff. I can't tell you the amount of good data that I get from physical therapy and occupational therapy. You read their notes and you call and, yeah, a patient came in late last Monday and the prior Wednesday and Thursday before that because he was drunk on his you-know-what because he'd been out partying all night long. And so the patients will tell the therapist that, but they won't tell the doctor that. And they don't think that we talk to the therapist. We sometimes don't. But the adjusters can get that data too. So it's all about data gathering. Direct association. Direct cause association exists when the event is necessary for the outcome to have occurred. A fall on the outstretched hand produces a fracture of the wrist. A fall on the right elbow doesn't give you lateral epicondylitis in the left elbow. Okay. We're going to talk about that in a minute too. And the reason I say these things because I review hundreds of cases, thousands of cases a year, and I can't tell you the number of goofball stuff that insurance companies have paid for over the last 10 years. I mean, in the millions and millions of dollars that were absolutely, unequivocally not compensable, and there was no causation ever proved up on it. And what that does is that takes money away from the patients who need the medical care, and they do have causation. It takes the money away from the docs. We're besieged. Okay? It takes the money away from everybody else, the hospitals, and it doesn't leave enough money in the system to care for the patients who really need it. So paying for non-causation, non-compensable injuries is a bad thing for everybody. Another example. You work for the city pool, and they use gaseous chlorine. And you're back there changing the tank, and it gets loose, and you suck a bunch of stuff, and you can't breathe. That's real straightforward causation. Unless the patient has cancer of the lung or is a 4-pack-a-day smoker, which you're going to ask him in your history, do you have any other things might be the cause of this, then that's pretty straightforward. Direct association. And those are the ones that we don't have any trouble with those. Those are the ones that are easy to deal with. We deal with them every day. Fell down, broke arm, fell down, broke ankle, stabbed in the belly, knife wound. Those are straightforward things. It's the difficult things, it's the things that are complicated, multifaceted, that slip through the cracks, and that don't have good documentation on them. Those are the problems that we have because the data wasn't taken prospectively. Everybody wants to come back later and look at the records and see, well, was the right shoulder included in this left shoulder problem? May or may not have been. And I can tell you that there's untold amounts of bad data out there in the medical industry right now. So we're all about increasing the quality of our data gathering and data analysis. Hill's criteria. Now, I never met Dr. Hill. These are tools and guides that we use to prove up causation. Temporal relationship, strength and association, dose response, replication of findings, biological plausibility, consideration of alternate explanations. Okay. Specificity, consistency, those are all important things. Did the patient wait a month? Temporal. Did he wait a month after his broken arm, where the bones are sticking out, to go to his employer and report the injury? Not likely. You can't walk around for a month with a broken arm. Now, he could have waited a month to talk about his sprained ankle or his sprained wrist or his overuse injury. Some of these things are pretty straightforward. The patient has an injury that couldn't possibly have gone a month or 3 weeks, and the reporting that it happened today. So the temporal relationship is important. The injury has to occur before the symptoms start. Repetitive activities, 20 repetitions per day of moving a box from here over to here is different than 2,000 repetitions per day of moving that box. And the amount of time that you do it, not just the amount of repetitions you do it, is very important to document. You have to be consistency in your findings. It's very important to be consistent. Every time the patient comes in, they need to have the same pain in the same place, the same mechanism of injury. I can't even begin to tell you the number of times I've seen John fell off the bulldozer and hurt his knee. Co-worker says John fell off the drag line and hurt his knee. His boss says he tripped and fell on a plank that was in the middle of. Okay, that's not consistent. Those things go a long way to prove that there is no causation, because there's no consistency in the history. It has to be consistent. Also, you'll find that if the ER doc takes a history, then the OCMED doc takes a history, and then the orthopod takes a history, they'll get 3 different histories. So, as adjusters, you guys need to home in on that kind of stuff. We all need to home in on that kind of stuff, because as doctors, if I get a patient who's told me the 3rd history, I'm going to be looking at him with jaded eyes and a real close, are you sandbagging, are you playing games with me? I can't cure somebody who's lying, because I'm going to be treating the wrong thing. Okay? So for the doctor, you got to get a good history. For the carrier, you got to get a good history. Everybody has to have a good history to treat the people properly. Yes, I went to work today, and my knee started hurting really bad. Nobody saw it. It's just about noontime, this guy started limping really bad at work. And you get down to it, and what are your sports? Oh, I'm a jogger. And so you're a jogger. Oh yeah, I did a marathon Sunday. I've had that happen. Marathon. Guy ran a marathon, then came to work 2 days later, on a Tuesday or Wednesday, I can't remember what it was, and he complained of his knee hurting. He said he hurt it at work. He just ran 26 miles on Sunday and then it hurt his knee at work. See, causation, because the symptoms and the problem occurred from something completely remote from the work injury that he sustained, and he didn't really have a mechanism of injury. So those things, we're going to say there's no causation there. And those kinds of claims shouldn't even get to ortho or shouldn't even get past the original. The adjuster should truncate those. We are on 12. We are on 13 now. Okay. Of Hill's criteria, 1, 2, 3, 4, and 7 are probably the most important, and 1 is the most important. The temporal, well, they're all important, but temporal relationship, strength of association, dose response, replication of findings, and cessation of exposure How long and how many times a day does the patient do what he does? You know, if a patient works on an assembly line, how many reps are there? How many years has he been doing it? And you're talking about a tendonitis. If the patient went to work yesterday and began doing repetitive activities and claiming today they have chronic tendonitis, doesn't make physiologic sense. Okay. They started working today and their symptoms started today. Or they started working 10 years ago and their symptoms started today. Those things are real important temporal factors. Every time the patient's examined, they should have the same findings, or basically the same findings. They're not getting new findings. New findings are usually not relevant findings. They're added to the case so that the patient can get either more compensability, more money, less hours, more theirs at home, or whatever. But you have to be very careful about letting patients add new items, new diagnoses, and new things to their problem that weren't documented in the first time. And if you're doing great documentation on the first time, then you don't have to worry about those things so much. Another real key is this. Stopping the offending activity doesn't stop the symptom complex. If it doesn't, probably didn't cause it to begin with. I had a patient I saw yesterday, new patient, consultation. She lifts boxes. She's a truck driver and she lifts boxes and pallets. She's got epicondylitis in her elbow. She has been off work for 6 months and it hurts just as much as it did 6 months ago. Wah. I just, it's just not believable. It doesn't make any common sense. And so you have to use your regular common sense brain along with your medical gathering information brain in order to sometimes look at these things on just a down-to-earth kind of way to look at the injury mechanism, at the symptom complex, and does the cessation of exposure improve the condition? It should, with very few exceptions. If you rupture a tendon, rupture the Achilles tendon, stopping rupturing the Achilles tendon isn't going to make it jump up and reattach itself. Okay? So there are high-velocity trauma or injuries that don't necessarily get better with removal of the exposure. Overuse syndromes, those are what we're talking about. Overuse syndromes typically get better when you stop the activity. I had a note here to talk about carpal tunnel, but I'm going to put it toward the end. Carpal tunnel is a real special case that I want to chat with you just a little bit about. Okay, exposure before the outcome. Cause must precede effect. It's the same thing again. Asbestos, lung cancer. If you are hired on to tear down a house today that's got asbestos in it and you get lung cancer tomorrow, there's no proof. There's no proving up of causation there. If you get it 3 years from now, then you may have a good case. If you go to your doctor today and you have inflammatory problems and he puts you on Relfin 750 milligrams POBID, an inflammatory drug, and then within 2 or 3 days you have a bleeding peptic ulcer. Those are the patients that you go really hard and dig into their history and find out where their peptic ulcer disease really started, because they almost always have it in the records. It's always somewhere. A lot of times they'll just tell you, oh yeah, I've had a bleeding ulcer on and off for 10 years. Okay. Now, the question you asked a while ago, is that our bleeding ulcer? If he's been on nonsteroidals for 6 or 8 weeks or 2 or 3 months, yeah, probably is. If he's been on for 24 to 48 hours, it's not. Because you've got to prove up again direct link, symptom and the cause. Yes.
How much, though, for 2 to 3 months on nonsteroidal?
Say again.
How much would they really have to be taking for an ulcer to develop in 2 to 3 months?
Well, they'd have to be taken. Typically, they would have to be taking the prescription dose. But you have to remember that it depends on what it is, which one it is, whether they have a history of it before. The 10% of all patients who take aspirin on a daily basis get an ulcer. 1 in 10. That's why all the nonsteroidals in the world were developed, because you have to take aspirin every 4 hours for it to work. And there are people who just go buy aspirin and take it every 6 times a day, insulting their stomach, and you can get an ulcer in 2 months doing that. So some people are very sensitive to it, and that's why the good doctor, the good PA, will always say, do you have any GI problems? Have you ever had any problems with Advil, Tylenol, aspirin, naproxen, naproxen, any of those drugs? And if the patient says, yeah. Oh yeah, every time I take it, it gives me a bellyache. Unfortunately, the patient doesn't get those in his medication regimen. That's just basic good medicine. Do a good history, and that goes into medical history. What problems do you have? And not only do you say, do you have any medical problems? No, not a one. Yeah. Come back, and the reason I know this is because we do a full history and physical on every single patient we do in my office. And then when they go to surgery, they get another preoperative history and physical. I bet you 10 or 15% of the patients have a whole bunch of stuff on the pre-op history and physical they didn't have on the regular physical. They just forget. People don't remember. If I asked you to tell me how many surgeries have you done, I bet you that 25 or 30% of you can't even remember them all. People say I have the same things. I've had diabetics forget they were diabetics. So, oh yeah, they do all the time. Or because it's a comp case, they're afraid, or because they don't want their boss to know. Patients lie. Patients lie for lots of reasons. So you need to be probative. You need to be proactive with these questions. Again, temporal relationship. It's just common sense. You don't have to be a doctor to figure out that if the patient says that he started work on Tuesday and he got hurt on the Monday before that at work, it doesn't make any sense. Strength of association. It's important. The strength of the association between the cause and the effect are real important. The higher the strength of association, the higher the probability that what you're dealing with is right. It's real straightforward. That's not complicated at all. Dose response. A real easy one to understand is cigarette smoker. If you're a half-pack smoker for 5 years versus you're a 3-pack smoker for 25 years, it's the dose response. You smoke a whole lot of cigarettes over a long period of time, you're much more likely to get sick than if you just smoke one cigarette every once in a while. Not always the case. Okay. You go to a production line and you do this 4,000 times a day versus the guy who's on the line over who's only going to 200 times a day. The chances are much higher that the 4,000 times a day guy is going to get the overuse syndrome, the tendonitis, the problems, as opposed to the guy who's not doing it as much. Not always the case. I see people real frequently who work in our local Dallas-Fort Worth area production lines, and they've been doing the same job for 30 years. I know ladies who've been typing like this 8 or 10 hours a day for 30 years. They can type 125 words a minute, and they wake up in the morning and their fingers are going like this. They go to sleep and they're still doing that, And they don't get no carpal tunnel. Okay? They're just made that way. But dose response curve is very important, and it will help you to prove up causation. It also helps you disprove causation. If the patient started on their assembly line today and they come in this afternoon, they had a fight with their boss and they come in this afternoon and they're hurting so pitiful and they can't move and they're just dying. Big suspect. You need to be able to repeat the results in any study, at another time, another place. So it doesn't matter what subgroup you're in. The studies for these types of things must be consistent. And the one that comes to mind the most, and one we'll talk about a little bit later again, is carpal tunnel syndrome. Carpal tunnel syndrome has been a compensable causation, direct related problem forever in the workman's comp industry. The tide has changed. I'm here to tell you the literature is out there. There is no direct link between repetitive activities and carpal tunnel syndrome, any more than the mother who sits at home and deals with the kids, or does a homemaker, or is a lady of leisure. There's no link anymore. The link is gone. It's been disproved. So you have to have a good link, measurable link.
Well, in what instance would you accept carpal tunnel? Because I still see it.
Okay. Depends on who you work for, depends on where you go, depends on what literature you read. But the new literature, the literature that I've been reading, okay, which is I think the definitive literature, there's really two instances in which carpal tunnel is, and we'll digress here for a moment. There's two instances in which carpal tunnel is compensable. One is you have a fracture with protruding bone. Okay, may or may not had to have an open reduction internal fixation or an X-fix or some type of surgery. Could just have a big spicule sticking out there pushing on the median nerve. You can get carpal tunnel with that. Carpal fractures, distal radius fractures. Distal radius fractures are the most common. Okay, where you fall on the outstretched hand and you got a fragment sticking up there that may or may not have been fixed properly. Even if it was fixed properly in a plate, there's a plate there and that can push on the nerve and it can give you carpal tunnel. And some docs, when they do the surgery, they automatically want to do a carpal tunnel release. That's a little aggressive, but you may have those questions. Can we do a carpal tunnel release on this? I think if the patient's got a bad fracture, they got to put a bunch of hardware in it. Let them go ahead and do the carpal tunnel. Cost you what, $300 nowadays, and it saves you an anesthesia and a whole other surgery, which is $10,000. So let them do it. The other reason is, stay with me now, awkward position of the wrist in full flexion, power grasp, vibration, repetitive, all four. If all four are present, then it can be considered compensable. What comes to mind? The reason is because I've seen it on multiple occasions. Vought Aircraft Corporation. They buck rivets. They make airplane wings. Have you seen they do riveting and all that kind of stuff? Well, these fuselages and the jigs and fixtures they work on are built by the government for Vought. Vought doesn't build their jigs and fixtures. They're just given, here, build this wing and this is the way we want it built. They've got to reach into these places with these bucking bars and they got to stick them up in a fuselage, and then there's a guy here with a power gun going bam, 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 and they're holding this bucking bar really, really hard. They do thousands a day for 30 years, and it just destroys their wrist joints. That's compensable. But typing, there is no link between typing and carpal tunnel syndrome. None, nada. If you take all of the people in the world with carpal tunnel who don't do anything for a living, okay, and I don't want to disparage folks that are able to lead a leisure life, because I just love that. But let's say that you're in a group of people who don't do anything manual, you don't do anything repetitive in nature, and you take all the people who do heavy manual labor and repetitive grasping, power tools, hand tools, things like that. They have exactly the same proportion to get carpal tunnel syndrome. There's no increase. So some of the carriers in Texas have already made the decision to not cover carpal tunnel syndrome, except for the 4 things that have to occur at one time. So,
and can you name those 4 specifically?
Okay. Awkward position with flexion, or ulnar deviation or radial deviation, mostly flexion. See, power flexion, power grasp, some type of vibrating tool or hand tool, okay, and very repetitive. Now, if you grab a bucket bar one time and you one of the guys, I think, sometime in the past was a supervisor. He came in and did one stent with it for 15 or 20 minutes, and then came the next day and said, I got carpal tunnel. But if it's repetitive over a long period of time, plus they need to have a positive EMG nerve conduction study. That's the gold standard test, and it should be significantly positive. I would reject most all of the carpal tunnels. I would reject, as opposed to the ones I would accept. Probably 100, 300 to 1, a bunch. Okay, we'll finish digressing. Again on 19 here, if you remove the exposure or reduce it, the disease goes away or becomes less common. Those are just basic kind of things.
Excuse me.
Yes.
Yeah, I wanted to say that I'm glad you brought this up. Sometimes there are some medical conditions that could present as carpal tunnel syndrome. For example, hypothyroidism. You could do that. People with rheumatoid arthritis, in pregnancy, anything that would cause congestion in the ribs and that lead to compression of the median nerve. So, but as to occupational physician, we don't usually do all those testing. So, should we be doing those tests when somebody, a typist, comes to you and say, I have wrist pain. Should we be excluding other things or just send them to the primary care provider?
I have a slide, there was a slide, we can talk about that, but yeah, I think that there are 3 medical causes for carpal tunnel-like syndrome. Okay? One is pregnancy. Look at pregnant women, they're always going like this. They're trying to wake those hands up because they get swelling and inflammatory changes and hormonal changes, and it causes swelling in the area. So they get symptoms of carpal tunnel. You never give a diagnosis of carpal tunnel to a pregnant woman. She's pregnant, and when she delivers, then you think about carpal tunnel if it doesn't go away. It usually does. The second one is thyroid disease, just like you said. Out of control thyroids oftentimes have the same kind of symptoms as patients with carpal tunnel syndrome. If you're considering this person has carpal tunnel syndrome, you need to be sure the thyroid's good. The third one is diabetes mellitus. Numbness and tingling, polyneuropathy is very common in diabetics, and they have the same kind of night numbness and tingling and waking up at night and tingling their fingers as patients with carpal tunnel do. But carpal tunnel is a mononeuropathy. It's a median nerve neuropathy. It's one nerve, median. Thyroid disease and diabetes mellitus are polyneuropathies, multiple nerves. You're going to have radial nerve, median nerve, ulnar nerve symptoms. You're just going to have one nerve. So with an EMG nerve conduction study, you can easily separate those out. Okay?
But should we be doing that in our clinic, or
If-
should we say,
If I'm
you need to see your
Yes, if I'm considering doing a carpal tunnel surgery on somebody, I'm going to get an EMG nerve conduction study for 2 reasons. One, this is part of what we're talking about. One is you want to prove up your theory. You want to prove up causation. Okay? If the EMG nerve conduction study is positive and it shows significant conduction delays and EMG changes, you've got carpal tunnel. It's very diagnostic. It's accurate. Now, if it's negative, there's a 20% false negative on EMG nerve conduction studies. It's usually because they're done too early. So be careful you don't do the study too early. But it's our responsibility to do 2 things. One, to prove causation, to prove that this is a diagnosis they have. It's also to prove that they don't have any other diagnosis. Because that increases our probability better than 51%. So if we prove that we do have carpal tunnel and we don't have thyroid and we don't have pregnancy and we don't have diabetes, then we can say with minimal hesitation that this is a compensable injury that's caused by what they do at work, and that this is the treatment that's reasonable for it. Then all we need to do is know how to treat the problem. So yeah, I would say you need to get an EMG anyhow, because that test proves up causation. If the test doesn't show carpal tunnel and it's been done more than a month post-onset, then the patient doesn't have carpal tunnel. The patient can have a cervical radiculopathy, in which case that's not our problem. We make a note to the patient, or we send them to their family doctor or their orthopedic surgeon, that's a non-comp doctor on the group insurance, and say, we think this patient may have a cervical radiculopathy or herniated disc in the neck, because that can induce the same kind of symptom, and get them proper treatment, but outside of our purview.
Do we order the TSH and the fasting blood sugar?
I would do the EMG first. If it shows a polyneuropathy, then I would recommend that the patient get their TSH done, get their blood sugar taken, go to the family doctor and get all those things done. But the EMG test is the test that will help prove in and prove out everything at once. We need the EMG test anyhow to prove that they do have carpal tunnel.
The IMO will not allow you to do this.
That's, well, I'm gonna be like the, what is it, the adjuster in place.
Okay.
So my question is, because I'm sitting here thinking, oh my God, is there gonna be like 5,000 EMGs coming in now? When someone comes in with
that's
symptoms.
Dr. Overfenny over there.
Okay, now, so we're talking,
So, I mean, is that at the treating doctor level, or are you saying that if they present with,
okay, I have a slide about this.
okay.
This is one of the diagnoses. It's misdiagnosed all the time. It's wrongly diagnosed all the time. And here I have my orthopedic surgeon hat on now. I have my other biased hat on. I think it should be diagnosed by subspecialty. The guy who's going to do the work on it should be diagnosing it. Primary care level, you're not going to treat it anyhow, maybe, you know. And remember now, we're talking about 1 in 300 or 1 in 400 people who walks into your office that got carpal tunnel. You're going to tell all those people, I'm sorry, buddy, that's not compensable. We don't take care of carpal tunnel syndrome. Now, if they come to you and they work at Vought Aircraft Corporation and say, yeah, doc, I've been bucking rivets for 30 years. Okay, you got to talk to them. And those are the guys we're talking about getting the EMG nerve conduction to prove up that it is, not that he's just not deformed or has a cervical radiculopathy and a claw hand, that he's got actual carpal tunnel because of what he does. I think we're obligated to order the test in that particular case because we really think we have causation. No, I would not, just to tell a person who doesn't have carpal tunnel, I don't order that test, because my tack on this now, and I've changed my tack in the last 3 or 4 years on carpal tunnel syndrome. Okay, I can't tell you the number of carpal tunnel releases I've done in a comp case, hundreds, because that was the standard of care. Everybody paid for it.
Dr. Hankey, I think Dr. Jones wanted
Yeah.
to say something about that.
I think that was pretty well covered. I think I just wanted to clear up what I thought you were probably saying, is that if somebody presents and they clinically have carpal tunnel syndrome, there's no doubt clinically they have it, but they do not have a mechanism of injury that would support that it's compensable. I would not work up those patients. I
Right.
would tell them that it's my belief they probably do have that. It's not caused by work, and that they need to go over here, to get further workup done. That there's not really a need to actually do any additional workup to prove they have it if the mechanism doesn't fit to support the causation.
And also now, so if we're at your level, the primary level, and you're seeing this patient in your office for the first time, if this case is 60, 90 days old, and you're just now deciding and getting the patient to you, and you think they've got carpal tunnel, now the problem is can you deny the whole claim, which you should, because there is no claim, it should be denied. But again, if the people are prospectively doing this data gathering, you're going to know before the deadline that you need to just take this claim and say, not only is it not compensable, there's no claim here. Okay? There's no causation in this claim, and we don't have a workman's comp claim to accept. That's where you guys are coming from, right? Okay?
Let me just, real quick, since you're talking about EMGs, what are your thoughts about who does EMGs?
There are two groups of doctors who do
Doctors,
EMG.
right? Not techs?
Can you want to turn off the recorder for me?
They said they're going to edit it.
I'm old school. Okay, I'm old school. I trained decades ago. But I think that if you say what is the highest best standard of care, the highest best standard of care is either a neurologist or a fellowship-trained physiatrist. Those are the people who have classically always done it. I send all of my patients who are going to get an EMG nerve conduction study to either a neurologist or a physiatrist who is specifically trained to do EMG nerve conduction studies. Now, there are a gazillion techs out there doing EMGs. I don't think surface EMGs are good. You need to do a needle EMG along with the nerve conduction study. If you look at an EMG nerve conduction study, the technical, it's not that hard to do. The interpretation, I think, is where you need to have a physician do the interpretation of it. The technical part of it, I think, can be done by a tech. I don't use them. That's my bias. As an orthopedic surgeon, that's my bias. But I'm old school in some things, Then there's the nurse practitioner, the PA, all the other physician extenders in the world. Where does their knowledge stop and where does the physician knowledge start? That's way above me. I don't make those decisions. All I try to do is think of what is the best standard, the best quality of care I can give my patient. I know lots of orthopedic surgeons now who don't see patients in the office. Their PA sees them. So the PA at Concentra sent the patient to me, and my PA saw the patient. So the patient's come from a PA to a PA, but he's never seen a doctor. Is that increasing the quality level of care when he comes to my office if I never see the patient? Unless I do surgery on him. That's up to the industry to make that decision. But that's happening in all the specialties. I had a patient 2 weeks ago I needed to send for cardiac consultation. Bad cardiac, big sucking murmur in the heart. And had previous stents and all kinds of problems. I sent him to a place that would do workman's comp screening. And I got the report back from the PA, and the doc had no doctor had ever seen the patient who needed a cardiologist. That's where the standard of care is going now, but that's not in this. That's above and beyond what we're doing right now.
Thank you.
There's lots of lectures we could go into based on all this stuff. They're going to beat me if I don't get going here. Okay, so biologic plausibility. Is it basically plausible? These things can help reinforce causation or disprove it. And they can be adjuncts too. They can help, consistency, specificity, biological plausibility, those things are important. If you have a history of a guy who's goes into work and he grabs onto something really heavy and he picks it up and he has acute pain and he puts it down and he hurts really bad and he goes and reports an injury and he's got a tricep tear, okay? From picking up something with his bicep muscle, it doesn't make biological sense because flexors tear biceps. When you push, that's an extensor function. So that's just basic biology, basic biomechanics. And so these things on slide 21, anatomy, physiology, biomechanics, ergonomics, basic mechanics. If you pull on something and you hurt a pusher muscle, that doesn't make any sense. There's no consistency, there's no plausibility, there's no biological plausibility. This accident or something may have occurred at work and he may have reported it timely, but it doesn't make any sense. It has to make biological sense to prove up causation. The mechanism of injury must be consistent with the pathology that it produces. I fell down off of a ladder and hit my head, and my right little finger is hurting. Well, if you put your finger down to block your head from hitting the ground and jammed it into concrete, that's plausible. Okay? But if I jump down off the ladder and hit on both of my feet, and I have an umbilical hernia, that doesn't necessarily make any sense. So you just have to weigh the things. You just have to keep your thinking caps on and think about things biologically and physiologically and anatomically when you do the history and physical. Consistency. It's got to be consistent. New findings? Not likely. If a patient comes in with a problem with his hand or his arm, and 2 months later, he's talking about his eye hurting. Oh yeah, this eye's been hurting the whole time. That's where it's so important, not only to prove up causation, but to disprove other causations. So in your history and physical, and there's a slide we'll talk about a little bit later with it. When you describe the injury, you describe the area that's hurt, lateral epicondyle. But you also take that there's no tenderness or pain over the olecranon, there's no tenderness or pain over the medial epicondyle, there's no distal forearm pain, there's no tenderness in the hand or problems, and there's no complaints of problems in the shoulder. You report all that stuff down. Now that sounds like overkill, and it is. But I can't tell you the number of times in the last 6 months or year I've had patients come in with roving pain and new pains. Every time something happens at work they don't like, every time the boss talks to them about laying them off, they got a new pain. They got a new pain. And if the first doc that saw that patient documented what he had and what he didn't have, that would hold no water. But what happens is we get these scribbles. Okay, I'm reviewing the doctor now for the carrier, and I'm looking at this, and I'm trying to prove this patient didn't have pain in his elbow the first time, or the other elbow for that matter. And I got nothing in it. I got a no pain drawing. Nobody filled out a pain drawing. Okay, those are wonderful. Okay, pain drawings are great. There's incomplete physical exam, incomplete history, and so it makes it impossible for the carrier to retrospectively come back and say, no, there's no causation there. There's no compensability of that injury. If it's in the records, it helps tremendously. It also helps you make your diagnosis and your treatment plan if you're a physician. Consistency. It's a real straightforward, easy thing. There's a term called specificity. It's a real important term. To explain it real simply, patient comes into your office as a swollen knee. Okay? Effusion or swollen knee is not specific. It's very general. Now, you can get a swollen knee from all kinds of stuff. You can get it from a fracture. You can get it from a ligament injury. You can get it from osteoarthritis. You can get it from gouty arthritis. You can get it from GC. You can get it from all kinds of things. Chondrocalcinosis. Okay? So using the term or using the diagnosis swollen knee really makes us no difference because it's not specific. So we need to have specificity. You have to rule out the other diagnosis. So the way you rule, if you have a mechanism of injury, the patient walks into your office and he has a swollen knee joint, and he has no history of injury, then you're more than likely looking at something that is not traumatic in its origin, and it's most likely not, there's no causation there, there's no compensability. He could have had any number of reasons why his knee is swollen up, besides a work injury. So he has to have a mechanism of injury that you've got to prove it up specifically with certain tests rule in, certain tests rule out. Be very specific about the physical exam, about the history of the injury, the mechanism of the injury, and everything else, and the limits on versus the limits not on.
We've got 10 minutes.
Okay. Causation assessment. You got to get a good occupational history of current working and exposure. You have to establish a differential diagnosis. You got to assess the medical problems. These are tools. These are just tools to help you prove up causation. Be specific about the type of work they do. Be specific if it's repetitive. Be specific about the amount of weight they have to lift. What position they're in. Are they in awkward positions? If there's a lot of bending, stooping, squatting, kneeling, crawling, climbing. Those things are very important. And then in the other part of the history, does he have arthritis? Does he have a history of gout? Does he have a history of diabetes? Does he have a history of other things that look and maybe mimic or predetermine that the patient has this condition, besides his work injury? Because you have to prove out those things as well as prove in causation of the diagnosis that you're doing. The standard is still the same in all reasonable medical probability. And so if you come in with a swollen knee joint and he doesn't have much of a history of an injury at all, and you haven't proven that he doesn't have the other etiologies, then you really aren't working on a solid base. You really need to cover all those bases. In workers' comp, the practitioner must discuss the relationship between the diagnosis and the work-related exposure. That's what we've been talking about the whole time. It requires estimating risk of developing the suspected diagnosis. Is it a high risk or is it low risk? Okay. The ratio of exposure to the symptoms is real important to weigh in your judgment. Again, subjective. Subjective. If the patient falls on the right hand and wrist, let's say he falls on his right hand, but he's still complaining of finger injury too. Is it reasonable to assume from this mechanism of injury that not only he hurt his wrist, but he also hurt his fingers? If he hurt his wrist and 6 months later he complains of fingers, you got a much harder time proving that up. Injuring your knee. Diagnosis, sprained knee. I've seen that about 1 million times. Sprained knee. Okay. Internal derangement, it's about the same thing. It means something's in the knee's hurt. It's deranged internally. It's not specific. The sprained knee could be a complete ligament tear. It could be a partial ligament tear. There could be a meniscus tear with it too, because major medial collateral and ACL tears have a high percentage of other injuries associated with it. A meniscus tear goes with it. And so, but it's plausible. It's biologically plausible if you have a ligament injury, but you also have a meniscus injury. And I can't tell you the number of times in the last 6 months that I, in my practice, and me reviewing other cases, have seen medial meniscus denied, medial collateral ligament accepted, ACL tear accepted, but we don't think they'd injured that medial meniscus. If you understand the mechanisms of these injuries and the plausibility of those, then I think it really helps you in determining, is causation there? If you have a medial collateral ligament and an ACL tear, is it reasonable to also have a medial meniscus tear? Is that mechanism of injury there? And again, if you do a good history and a good physical, and be very specific where the pain is, how long after the injury occurred did the swelling come up? Did it come up the day after, the week after, the month after? Is there popping, catching, giving way? All those symptoms, no matter what joint it is, those things need to be included in all your physical exams. Because we've been so serious for so long. Yes, my boss told me he was going to fire me this afternoon, and boy, I'm hurt real bad. I mean, that, I can't tell you how many times they go. And you know, employers sometimes they don't get it. Patient got hurt a month ago, and the doctor comes in, and the patient needs surgery, and he fires him today. He's never going to get better. You know, as soon as they get fired, as soon as they get laid off, as soon as they get an attorney, they quit getting better. So you have to deal with those things. But if you've proved up your position and you've disproved other positions, it makes it so much easier for everybody to deal with this properly. Even if there's a bunch of subjective overlay, that the patient is angry at his boss, he's angry at his doctor, he's angry at the insurance company, he's angry at everybody. You can't out-anger, you can't out-argue objective, well-documented, readable notes. It comes back to the same thing over and over again. And again, let's talk about this. Let's talk about the wheres, the whens, the hows, the whys, what happened, the body part, specific body part. Okay? Be compulsive, be accurate, be specific. Can't, you know, I just can't beat on you enough about that. And use pain drawings. I saw a DNO, a decision or order by the state not very long ago on a case that hinged on a pain diagram. The pain diagram initially showed right-sided body injury, and then the patient 6 months later was complaining of left problems and got a lawyer, and everybody sued, and then the state came back and said, well, here's the drawing that the patient did and participated in. He said there was no pain on the left side. Wah, no injury. Just a pain drawing is what the finding of facts were in the report. I see them all the time. Those cases where there's no early on prospective documentation of causation or non-causation, those cases when they go to decision and order by the state, we lose. We lose almost always because the people on those boards and those committees are laymen and they feel for the patient who comes in with a walker and a cane and a crutch and they're all pitiful as they can be. So we have to prove up our part better than everybody else. And it's done prospectively, not retrospectively. There it is. How, where, all those queries. These are just more tools, you know. When did the job begin? What is the specific agent? Exposure in the past. Has he been working asbestos for another company for 30 years, you know? Household members. Pets. I don't know that I've ever asked anybody whether they had a pet, but there could be some allergy stuff. All of these questions, if you keep these in your armamentarium when you have a tough case and you're wondering, these will help you. They're not the do-all and the see-all, but if you don't ask, you don't know. You'll never know. Subjective complaints. You got to have it in your history and physical. You got to have, or the history. Subjective complaints are just that. They're subjective complaints. You can't treat them. You can give them a they're there, I understand your pain kind of thing, but they don't prove up or disprove anything. They can point you in the right direction to help you. You know, my knee hurts. Okay, we're going to go look at the knee. But patients have 1 out of 10 pain if you cut off their arm, and they'll have 10 out of 10 pain if you have a hangnail, and all in between. So you can't use pain. You have to use objective data in order to determine what we're talking about today is causation and compensability. Those are just absolute keys. The first thing is the most important thing. Put your hand on the patient. We have 3 rules in my office. 1, no doors are closed during the exams. Everybody, I have an open policy. No behind doors, no behind closed doors. Number 2 is I always sit down so the patient's head's higher than mine, unless I'm doing something specific. And number 3, I touch the patient. You gotta touch the patient. If you don't touch the patient, you can't feel what's wrong. So I bet you 20 or 30% of the patients that I see had seen doctors for 6, 8, 10, 12 weeks. They've never been touched. They've never been touched. So docs, PAs, we got to touch people. It's just part of it. You got to, in order to do a good exam, that's just good doctrine. That's not something special about this. You look for atrophy, you look for reflexes, you look for all the good things that you do on a good exam. And then when you document the patient has acute lateral epicondylitis with tenderness and pain over the extensor muscle group and the mobile wad bundle, they have loss of extension or loss of flexion, pronation, and supination. They also have no tenderness over the medial epicondyle. They have no forearm or wrist hand or pain. They have no swelling or pain or tenderness over the olecranon process, and there's no complaints of any pain or problem in the shoulder. That locks you in to this area right here. And if they do this for a living, there's good causation there for epicondylitis. But you've got to rule out the things too in your documentation. Diagnostic studies. Sensitivity versus specificity. We can chat about those things if you want to. You know, a sensitive test, ability to identify that they do have this diagnosis. Specificity, the ability of a test to identify the people who don't have this problem. So you need to have specificity and sensitivity in your testing. Okay? Not only do you have to establish for causation, you have to establish the patient has diagnosis X. You have to also establish the patient does not have diagnosis Y, Z, B. Okay? Because that helps you. It immediately, rapidly raises up your bar for in all reasonable medical probability. If the only thing you can say is that we think they have this, that's not so good. You got to be able to say what they don't have to. Thanks. Accuracy, likelihood, positive test, negative test, those are pretty straightforward things. One of the things you need to understand about some tests is that they can be real positive, they can be real negative. EMG nerve conduction studies we talked about earlier, 20% are false negatives. So be sure you don't order them too soon. Some tests are good, some tests are moderately accurate. Use your diagnostic gold standard testing. Don't use a 0.6 Tesla MRI scan if you can use a 3 Tesla MRI scanner, because you get a much better picture. Use the reliable, up-to-date data, and you get better ability to prove up compensability. All this data that we're using is only as good as the accuracy of the person taking the data and writing it down. So you have to be accurate from the very beginning. These are all tools we've been talking about. That's all they are. It's a bunch of tools. And these tools are used both prospectively and retrospectively. It's better to use them prospectively. The accuracy varies with the accuracy of the data collection and the studies and the interpretation of those studies. So the people who are interpreting them, they put into our ability or not having our ability to prove up causation. So those are the things. And remember one thing, one of the most important things, is that every single thing you write down, every single thing that you communicate one way or another is going to be reviewed by a judge, a therapist, the adjusters, a designated doctor, an IME doc, the BRC members, and the peer review docs. So when you write notes down, you're not just writing them for yourself anymore. When I started, the record was my record. I'm writing it for me. Now you're writing it for everybody else in the world. So be accurate, be consistent.
That's excellent. Thank you, Dr. Sure. Just to conclude this particular section, keep in mind the general summary of the causality is that these following things, I'm not going to go into it because we're a little bit behind schedule at this point, but overall, the guidelines, the evidence-based practice, the early intervention that when they go and see the treating, or say the specialist sees them, that there's clarification on that causality again, and we're going back to the common ground of, again, are we working upon the same initial findings so that we don't allow the case to get maneuvered or going into a different track. it's very, very critical that the causality then is defined and that we document that successfully at the get-go. These are some other just general summaries that you look at the actual case, you visit with the case manager, you identify the job description. If you don't have the job description, you ask IMO for the job description, or you call the specific employer and you ask for the job description so that we can provide the necessary tools to ensure that the causality is documented effectively. And we always talk about documentation. I will say that one of the things that we keep trying to improve is getting and obtaining the medical records. It's so critical that we get the medical records, and everyone works so hard in trying to retrieve them, but the medical network is very responsible, and we are accountable to ensure that we're getting those records early on and not chasing them down. So just very critical there. So overall, effective documentation, the early intervention of all of the diagnostics and evaluation, and all the therapy notes. We tell our physical occupational therapists when they're seeing something, when a patient comes into their clinics and they see something that just is kind of outlier and ordinary, that they're documenting that and providing that to the networks or to the treating or the specialist, whatever the case, but mainly the treating, to ensure that nothing is going on a different pathway. Evidence-based practices is very critical, and I just want to remind providers that the medical disability guidelines are as critical to look at the return to work, the dates, the optimum dates that are required, and ensuring that you're following evidence-based practices within the spectrum of treatment care. We are all accountable. We're all accountable together to make sure that the communication is there, and that is how we're going to advance the quality of the care. It's very important that we're accountable to compliance of forms. Aisha mentioned about the DWIC 73s. We find way too often where the DWIC 73s are just copied from time to time that they're seeing the doctor, but the date's not changed, or the signature is missing, or certain parts of the 69 is not filled out correctly. It slows down the continuity of care that we mentioned about in terms of the medical network being responsible for, and the carrier in terms of continuity of care. Remember to, and also understand that when we hear the voice of the injured employee and they're telling us how they're feeling, or they're maybe expressing their voice of frustration, that they don't understand what their expectation is, that it needs to be communicated. Any party that hears that needs to communicate that back to the network so that we're able to really move the case along or communicate to the right parties to ensure that it's a full impact of quality care that we've been talking about today. How do we impact it? How do we advance it? The next part of the session we're going to go through is identifying again other areas and really talking about the landscape of outcomes. It's a very big part, very critical part of this presentation.